In pursuit of health and wisdom. Sapio with Buck Joffrey.
Welcome back to Sapio with Buck Joffrey. This is Buck Joffrey, and today my guest on Sapio is Dr. Corey Frucht, a board-certified dermatologist. Corey's a graduate of the Yale School of Medicine, completed his dermatology training at UC San Diego, and is a faculty member of the American Academy of Dermatology. He also serves as the president of the Tri-County Dermatology Society of the California Central Coast area. He practices here in Santa Barbara. His practice is known as Santa Barbara Skincare. Corey, welcome to Sapio.
Thanks for having me, Buck.
So it's great to have you on because, obviously this show has really focused significantly on aging and longevity and that kind of thing. And it's funny, Corey, when I was this morning, I was going for a hike. And just thinking about our podcast today, and I was hyper aware of people walking by me. And I kept thinking, gosh, I can really get a sense for, this is obvious, but I can really get a sense potentially of how old somebody is or how young somebody is based on just their skin. And I never really thought too deeply about why that is. Now, of course, I'm a facial plastic surgeon by training, so I did nearly 1,000 facelifts. There is a lot of elements of gravity there, but there's also just the skin itself. So what is it about the skin in a young person that makes it look young, whereas somebody who's older, it looks like older skin and gives it away?
So there are a lot of changes that occur in time. So young skin is supple skin. It's well hydrated. Very few, if any, fine lines or coarse lines. Texture is even. Very few areas of discoloration, few brown spots, few red spots, and very few growths. So just nice and smooth. There are, of course, benign growths that can develop in even very young individuals. But as we age, we tend to acquire more growths, both benign and sometimes cancerous or precancerous.
And I guess the question is why? Why is it that, you've talked about hydration, you talked about the wrinkles, but underlying there is some sort of machinery, something that's changing as we get older. And what exactly is that?
So quite a lot changes as we age. I like to think of aging of the skin in terms of a few different general components. The first of which is structure. So as we age, we lose skin mass. We know that we lose collagen, which is the primary protein constituent of skin. But not only are we losing skin in a literal sense, we're losing tissue underneath the skin that supports it. So the fat underneath the skin atrophies, we lose that. Muscle and even bone, we lose all of this as time goes on. So it's almost like a balloon that becomes deflated. And as you say, gravity sets in and pulls everything down. Right. So that's where you're seeing some of those structural changes that occur in time. Also, we know that in particular with chronic UV exposure, fine lines set in, color changes. So UV exposure is a big determinant of aging of the skin. Also, just color in general, even without sun exposure, the skin tends to change in color. Color becomes less even, texture can change. And again, we acquire growths. So right. All of these things change in time.
So when you're talking a little bit about, the different changes that happen in people's skin as we get older, there's some it seems like, and it's anecdotal, I don't know that there's anything published on this, but people of color, their skin does seem to age, less readily than somebody who's really fair. Is there a reason for that?
Absolutely. And to contextualize my answer, we've got to dive into a little bit of basic skin biology, if that's
sure,
okay.
That would be great. Yeah.
So there are cells within the skin called melanocytes, and these are critical cells that produce a type of pigment called melanin. So melanin is an intrinsic method of protecting our skin from UV damage.
Right.
So those who are more darkly pigmented, interestingly, have about the same number of melanocytes as those who are fairly complected, but their melanocytes produce far more melanin. So that's what gives pigment to the skin. So those who are more pigmented intrinsically have much better sun protection. So it's almost like walking around with sunscreen on around the clock. So there's an innate, intrinsic protective mechanism there at play. So it's really because of photoprotection. And there may be other general tendencies based on complexion where people live in the world. Maybe some people aren't doing as many outdoor sports and just aren't getting as much sun. But the primary determinant is the amount of melanin in one's skin.
Let me ask you this. So what exactly is it about UV exposure, and what is it about the sun and what is it damaging sort of at that cellular level? That, I mean, because obviously if you've got more pigment, you're saying that you're essentially protecting these other components of the skin. What are those other components of the skin that are getting damaged from ultraviolet exposure?
So vast majority of skin cancers are derived from the very top layer of skin called the epidermis. Mm-hmm. So those melanocytes have these tree-like projections that distribute that melanin throughout the epidermis to protect those superficial cells. What's happening with UV damage in a simplistic way is it's causing DNA damage. It's causing direct damage to the DNA, the molecular machinery underlying the way in which these cells replicate and turn over. And like any other organ that can develop a cancer, we think there are probably multiple hits at play. So, chronic exposure that's cumulative, there may be some underlying genetic susceptibility, but fundamentally, UV exposure is causing DNA damage. Right. And we can talk a little bit about different types of UV because it is pertinent to this conversation. Sure. So there's 3 types of UV. We're talking about ultraviolet light, UVA, UVB, and UVC. Fortunately for us, most UVC is filtered out by our atmosphere. Okay. So it's primarily UVA and UVB that are affecting our skin. UVA has a longer wavelength and therefore penetrates deeper into the skin. UVA is the primary determinant of aging of the skin, we think, because it's really getting through that entire epidermis and into the dermis beneath it. It's UVB that causes sunburns and we think is a greater contributor to cancer risk. So both UVA and UVB do increase skin cancer risk. Primarily it's UVB exposure chronically that increases cancer risk.
Got it. So when you're putting on sunscreen, I guess this is probably a good place to talk about sunscreens because if, ultraviolet radiation has so much role in this aging issue, what are we protecting there? What do they do? Are they protecting us from both UVA and UVB, or how does that? Or does it depend on the sunscreen? Maybe you could talk a little bit about that because there's like a million different kinds of sunscreens out there. There's a lot of marketing about sunscreens that it's confusing for people. Maybe you could kind of give us a little bit of a sunscreen 101.
I'd be happy to. I think that's sort of the meat and potatoes of this conversation because chronic UV protection is the most important way to prevent photoaging of the skin and the most important way of protecting one or minimizing risk of skin cancer. So I'll definitely answer your question. I'd like to talk a little bit about sun protection in general, though, if I may.
Sure.
So what I like to tell my patients is I really feel as though physical protection from the sun should be the first line of defense. What I mean by that is minimizing direct sun exposure on your skin. Now, I don't tell my patients to live in a cave, and certainly practicing in Santa Barbara, nobody would take me up on that suggestion. Yeah. But it's finding ways to minimize damage. So that can mean, if you're at a picnic, you're trying to find the one bench that's under a tree, you're actually intentionally seeking shade. Or if you're very active and into outdoor sports, you're trying to set up your tennis matches or your swims either very early morning or late afternoon. So we know the UV index is highest in the middle of the day, depending on the time of year between roughly 10 a.m. and 2 p.m. So we try to minimize time spent in the sun during those hours. And the other side of physical protection is trying to cover up directly, meaning when feasible, a wide-brimmed hat, wearing sunglasses, a long-sleeve sun protective shirt, and physically covering up. So sunscreen really is the second line of defense, in my opinion, for a number of reasons, and in part because a lot of people don't like slathering that on from head to toe, and it's messy and it's sticky and it takes too long. So sunscreen in that scenario is used more for exposed skin like your face, your neck, your hands. Mm-hmm. Sunscreen, to answer your question about UVA versus UVB, it does depend on the sunscreen, but these days most sunscreens block both UVA and UVB. And you can confirm that by making sure that your sunscreen says broad spectrum on it. That's what that term means. So blocking UVA and UVB. Okay. So a lot of my patients want to know what level of SPF is sufficient, and this is an interesting conversation. Yeah. There's an idea out there that there's no benefit in using anything above SPF 30, and there is some truth to that. So SPF 30 provides almost as much protection from UV light as SPF 40, 50, 70, et cetera. The problem with telling patients to use SPF 30 only is the studies that demonstrate the effectiveness of sunscreen are very controlled experiments in which participants are using a fixed amount of sunscreen that far exceeds what we use in reality, right? In the real world, we put a very thin layer of sunscreen on. And if you do that, you've got less protection than you think. A thin layer of SPF 30 might confer SPF 15 or 20 equivalent. So I tell my patients, overshoot, use your SPF 50. Even if you've got a thin layer on, you've probably got 30 on effectively, and that should be sufficient.
When you're choosing one of these sunscreens, like what are some of the things you should look for? I mean, there's all sorts of marketing gimmicks, right? So like, how do you know that you've got an effective sunscreen? Is there like a place you can look at to see, how effective a sunscreen is commercially rather than just relying on marketing?
So, sunscreens are pretty well regulated. And in terms of the SPF ratings, that's all determined by government agencies. So there are specific definitions as to what SPF 30 versus SPF 50 means. And diving into that probably won't be of great interest to your listeners, other than to say that the most important things to look at, really, in my opinion, are broad spectrum and the level of SPF protection. Beyond that, it comes down largely to preference and feel. So I don't personally have strong brand preferences. There are not specific ingredients I tell my patients to avoid, although we probably should at some point talk about ingredients in sunscreen. It's mostly broad spectrum, SPF 50 plus, and there's the idea of chemical versus physical blockers. I don't like to malign chemical blockers. Physical blockers are slightly preferable in that they truly provide the broadest spectrum of protection. Just
let's provide a little clarity on that, because I think maybe that's not something that people know a lot about. So when you're talking about physical blockers, you're talking about, like a zinc oxide or something like that versus.
That's exactly right.
Right. Maybe you could just kind of give a little overview of that and kind of tell us what your take on it is.
Sure. So the two types of active ingredients for sunscreen are so-called physical blockers and chemical blockers. Physical blockers can sometimes also be referred to as mineral sunscreens. So these are zinc and titanium-based compounds that literally physically shield the skin from direct UV exposure. In contrast, chemical blockers are chemicals like avobenzone and oxybenzone that are synthetic chemicals that actually are designed to absorb that UV energy. So there are some advantages and disadvantages to each. The advantages of physical blockers are that they truly provide the broadest spectrum of coverage, and they're very hypoallergenic. While it's not uncommon, occasionally patients can be allergic to the chemical sunscreen blockers. That's the scenario in which I most frequently find myself specifically recommending physical blockers. The reason I don't recommend physical blockers to everyone as a blanket recommendation is they tend to be far less cosmetically elegant than the chemical blockers. So chemical blockers tend to be in the more watery and light preparations that patients like using. My fear is always that if I recommend a very cosmetically inelegant product, patients are going to be disinclined to use it at all.
Yeah.
So I feel as though the most important thing is for patients to find a sunscreen they actually like the feel, the weight of, the smell of, and will actually utilize.
So is there a way, presumably when you got these blockers or whatever sunscreen you're using, it's going to, for people who like to get a tan, is there a way to get a tan without not having damage to your skin? Or is that just one and the same?
I'm really glad that you're asking that question. So I like to somewhat facetiously tell my patients that a tan is your skin's way of screaming out and trying to protect itself when you fail to adequately do so. So tanning is an intrinsic protective mechanism. It's a response to direct DNA damage that stimulates melanocytes to produce more melanin, and it does confer additional protection. The problem with relying on that protection is, by definition, you've got to incur the damage.
Yeah.
To get there. And so we don't recommend this idea of a base tan or getting tan to protect yourself. So that the damage has been done by the time one is tan.
So shifting away from the sun, because I think we've hit ultraviolet pretty hard, but from a purely cosmetic perspective, let's just take, cancer aside. And maybe you don't, because maybe it's sort of one and the same here. But what are the most important things you can do to keep your skin appearing young for a longer period of time?
So for sure, sun protection is numbers 1, 2, and 3. We've
Right.
talked about that.
Yeah.
Beyond sun protection, basically it's the same things that would make one healthy internally and promote overall health that we think contributes to health and therefore healthy appearance of skin. So simple things like having a healthy, balanced diet, lots of fresh fruits and vegetables, lots of antioxidants, maintaining adequate hydration, getting enough sleep. Avoiding smoking. We know that exposure to cigarette smoke and smoke in general can prematurely age the skin, as well as so can excessive alcohol consumption. So basically having a healthy, balanced lifestyle confers benefits to the appearance of your skin as well.
So diet is part of it as well. Is there any truth to specific kinds of diets? Is there certain things that you should try to make sure that you get in your diet to get adequate health? Or is that the same again as, let's the reality is that skin is the largest organ in the body, and it's like any other organ. And what are you going to do to keep this body healthy? That's what you're going to do for the skin.
Absolutely. As you know, nutrition science is notoriously challenging in that it's hard to do controlled experiments and really isolate specific variables. So I don't believe there are any studies really proving that a specific dietary component or chemical or food, whatever it may be, is directly linked to skin health. But in general, we know antioxidants, like I said, fresh fruits and veggies are beneficial in terms of health overall. And there's some correlations and studies showing that it probably prevents photoaging or minimizes photoaging of the skin. But the direct answer is there are no specific foods that I advise my patients to consume in higher quantities or to avoid necessarily.
Okay, and I guess the next question along that lines is that there are supplements that people talk about, whether that be biotin. And I know, for example, another one that I keep seeing pop up because it must be, because I'm looking at longevity literature all the time, and my cookies are getting bombarded with things for people who are trying not to age. But Elysium has a new product called Mosaic, which they are hitting hard and showing lots of scientific studies on with regard to benefits in collagen. I don't know if you've had a chance to look into any of this, but I would love your comments on supplements as it relates to skincare.
For sure. As a physician and a scientist, my job is to be a skeptic by nature.
Right.
And the challenging thing in the space of supplements is that virtually all the data that exists is from the companies that are manufacturing these products.
Right.
The products themselves are oftentimes proprietary. Either the vehicle is or the exact blend of herbs and spices, so to speak, that are in there.
Yeah.
It's highly confidential. So my take is it is impossible for me as an objective scientist to look at this and tell patients that these do or do not work. And my standard go-to is, listen, most of these are probably not going to cause harm. I'd maybe avoid the most expensive of them, given that there's not really objectively proven benefit in my view. But
Sure.
I think the jury's out, and we just don't really know regarding supplements. I think one that I get asked about a lot specifically is biotin. So maybe we're talking about that.
Yeah, sure.
So the idea that biotin may be beneficial for skin health stems from the fact that in those who are biotin deficient, there are skin problems. You can develop rashes, the skin breaks down, hair can thin, nails become brittle. And then the logical jump from there was, well, perhaps if we have patients take biotin at higher levels, we can increase hair growth and reinforce strength of nails and promote skin health. Unfortunately, that's largely been debunked by pretty good studies at this point. Biotin is beneficial in those who are biotin deficient, which in our country, given our Western diets, is exceedingly rare. So for those who have normal biotin levels, there is no demonstrated benefit of biotin. And in fact, there is some potential for harm in that it can interfere with blood work. It can affect thyroid assays. It can affect troponin tests. That's a marker of cardiac injury, as you know. So there is some minor concern or risk with it. But biotin specifically seems not to do much in the skin, hair, or nails.
I'm curious about, there's a lot of products with collagen too. And it's like, is that something, obviously collagen becomes a problem with our skin as we get older, but it certainly doesn't seem like it's necessarily that our diets in the West here would be deficient in collagen. So would it, for the same reason, would there not really be any benefit in taking that in your view?
So the story with collagen is, as you know, collagen's a peptide, it's a protein.
Right.
So the way we absorb proteins is they're broken down in the stomach and the small intestine into their building blocks, amino acids. So they're not absorbed as collagen, it's absorbed as amino acids, and your body then sends it where it sees fit. So this idea that we can consume collagen is a little bit of a misunderstanding, I think, about how that works. So even though there are some small, poorly designed studies showing possible benefit of collagen, there are many studies showing limited, if any, benefit. And just based on our basic understanding of this biology, I'm very doubtful that oral collagen supplements are a benefit to the skin.
It almost reminds me, and just comes to mind that there is this parallel between what's going on with the skin and the structural framework of the skin and simply what we've been calling sarcopenia, right? Which is the sort of muscle atrophy and breakdown as we get older as well. I mean, do you think that's a fair parallel?
Absolutely. Muscle atrophies. I mentioned atrophies in the face, but it atrophies all over the body, and we do lose protein.
And collagen's a protein.
Collagen is a protein. It's important to have adequate protein in your diet, but I don't think there's any benefit to making sure that protein's in the form of collagen.
Let's talk about lotions and potions, because that's a big one, right? And so what kind of topical skin lotions are actually beneficial to combat aging?
Really just a few that I think have adequate science to routinely recommend them, and the first of which is so-called retinoids. So many of your listeners will be familiar with these. So these are vitamin A derivatives, the best known of which is retinol, which is over the counter. And then there's tretinoin, which is a prescription form. Tretinoin is the generic name for Retin-A. There are others as well. So these vitamin A derivatives do a lot of wonderful things in the skin. So they exfoliate, they help to open up pores, and are used commonly to treat acne as they prevent breakouts. They increase turnover of cells, so they can improve texture and tone and color. They sort of give you a glow. And it's the one topical, really the one medicine that's been shown to actually boost collagen within the skin, and has been really proven scientifically to minimize the appearance of fine lines. So there's a lot of benefit to using retinoids and very little downside to using them. So I think that's the most effective topical to combat photoaging of the skin.
Does that dry out skin a little bit too?
It can, there are some downsides and risks if used too aggressively, or if a patient's just too sensitive. There can be redness or irritation or peeling of the skin, sometimes sun sensitivity. So I'll occasionally have my patients use it maybe every third evening instead of every single evening. Also, by applying a moisturizing cream on top of the medicine, you can mitigate the drying and irritating properties of it. But most patients are able to tolerate retinoids.
Is there a big advantage of having the prescription strength as opposed to, what you might get over the counter then?
For some people, yes. So the story there is retinol, which is over the counter, and retinoic acid, which is tretinoin, prescription Retin-A, are very, very similar. So the retinol is the precursor form to retinoic acid. It's the retinoic acid that's active within the skin. So the issue is there's great variability in terms of how well individuals will convert that precursor, the retinol, to the active form. Some individuals will have very little effect from it. Others will convert quite well and will see almost as much benefit as they would with tretinoin. So the prescription form is more reliable. It's more consistent. We know what it does, and it works for pretty much everyone. So it's preferable, but retinol over the counter does work for most people.
Is there anything else that you think is that has enough research behind it that you would think it would be worth talking about?
Yeah, so a lot of antioxidants have been looked at. There's a really big field out there, and people have looked at a lot of different potential components. I think the two that have the best evidence for them are vitamin C and vitamin E. Both antioxidants that, when applied topically to the skin, seem to minimize progression to photoaging. I don't think that's definitively proven, but I think there's pretty good evidence to support it. So I do talk to my patients about that. But beyond those three things, a lot of it, unfortunately, I think is probably marketing, or the jury's out. We just don't have convincing data yet.
So I guess the three things, and some sort of retinoic acid or retinol product, vitamin C and E, which you can get a number of products that combine the two, I think. And then probably just some really good moisturizer. Anything about moisturizers in particular that you would talk about?
No, in the context of inflammatory skin disease, it matters. But in terms of just aging of the skin, maintaining adequate hydration systemically means you're taking in enough water in general, and using any lotion or cream that you like is probably sufficient. I don't think there's reason to recommend one specific one over another.
Would love to get your take on some cosmetic procedures for this, because here's what I was thinking again about this show. And as I mentioned, I used to do a lot of facelifts, and I remember one case in particular, and this woman had so many laser procedures. She had so many CO2 lasers. I think she was doing it every 6 months or so. And when I was kind of lifting up the skin, I was like, this was remarkably different skin than any other Caucasian woman that I had ever done a lift on. And it was strong. It was tough. Mm-hmm. So do you think that is just an N of one, and I was seeing something that maybe was related just to her? Or do you think there's something really to some of the cosmetic procedures that are stimulating collagen, such as lasers and microneedling or microdermabrasion? What's your take on these things?
I think it was not just an N of one. That patient had ablative procedures, and we know that ablative skin procedures generate collagen.
Right.
So things that cause controlled injury to the skin, like lasers, like microneedling, are absolutely of benefit. And sometimes you can walk around and literally just tell who's had CO2 resurfacing.
Oh gosh,
the skin takes on a smooth, shiny texture, and these patients sometimes look porcelain even decades after a treatment.
Yep.
So your observation, I'm sure, is a common one for plastic surgeons like yourself, in that these patients have dense, increased collagen, more so than would be typically age appropriate.
They're not fun to do facelifts on at all. The skin's really hard to lift, but it's good. They don't need facelifts often because they're managing the gravity issues much better. What about patients of color though? Like, I mean, listen, look at me, right? I mean, I am, I've got some pigment here. Fortunately, my skin doesn't seem to be aging quite as quickly as others who are my age and men, but I think it's one of these things that, a lot of people have. They have some pigmentation, and they can't necessarily do an ablative laser because of the risk of hyperpigmentation afterwards, some sort of inflammatory hyperpigmentation. Do you have some thoughts on what patients with, those kinds of skin, ethnic skin, can do in terms of, resurfacing?
Absolutely. So ablative procedures like CO2 lasers, like erbium YAG lasers, literally damage the skin and cause a controlled burn, essentially.
Right.
So that carries risk for anyone, more so for those who are more darkly pigmented, because one of the risks is hypopigmentation, right, where the skin is permanently lighter. Mm-hmm. Now, there are many lasers that are not fully ablative, but rather are fractionated, meaning instead of a continuous field of damage, it's very focal columns of injury, sparing skin in between. The idea is that intervening skin can then help the damaged skin regenerate with minimal risk, less risk of scarring, less risk of dyspigmentation. So the first piece of advice would be to make sure that a fractionated device is being used. And the second issue is for ablative procedures, these are pretty serious heavy-duty procedures that even in lower risk patients should be really done by experts, board-certified dermatologists, plastic surgeons, not going to your local medi-spa where they're maybe dabbling in this. You want somebody who is doing a lot of them. So I think those are the two main ways to minimize risk: using the right device and seeing the right physician who's very experienced in doing that procedure, and in particular doing that procedure on patients who have more complected skin.
Yeah, so you mentioned hypo, like making it lighter. My thought was the concerns that I've heard about were actually more what you call post-inflammatory hyperpigmentation, or like getting really, dark afterwards. Is that equally? Is there one more than likely?
Yeah, so both are risks. The scary one is the hypopigmentation, because when that occurs, that can be permanent, and often is.
Yeah.
Post-inflammatory hyperpigmentation, where the skin is darker after a procedure, is almost always a temporary, albeit sometimes frustratingly long-lived complication, but one that is treatable. So either can occur and is at higher risk of occurring in those who have more darkly pigmented skin, but it's the hypopigmentation from ablative lasers that's really a feared complication.
The other procedures that we mentioned too, microneedling, microdermabrasion, they're all ultimately, everything that you're doing there is causing sort of a controlled injury. And functionally, that's essentially what all of these things are trying to do, right? Is get some promotion of injury, and then the hope is that that skin comes back stronger. And is that effectively a fair assessment of what we're doing here?
That's exactly right, Buck. So it's a controlled injury that is stimulating production of new collagen within the skin.
Let's move to skin cancer. You are an expert in this space, of course, and and obviously we don't have doing an entire show on skin cancer would be probably worthwhile, but I want to make sure that we cover this topic while we're here. First of all, maybe you could talk a little bit about how big of a problem skin cancer actually is right now in the United States, like in terms of epidemiology.
Absolutely. So skin cancer is a tremendous problem and tremendous burden to our healthcare system, just in terms of disease burden, but in terms of the financial strain that it presents as well. There are over 5 million cases of non-melanoma skin cancer within the US every year. And by non-melanoma skin cancer, I'm referring to the very common basal cell carcinoma and squamous cell carcinoma. Furthermore, there are roughly 200,000 cases of melanoma, and there are some other rare skin cancers that exist as well.
Yeah.
So all told, close to perhaps 6 million cases per year. So a tremendous burden on our healthcare system.
Luckily, most of the skin cancers that you come across are of two types, presumably, which are the basal cell carcinomas and squamous cell carcinomas. Those are eminently, in most cases, eminently treatable. Is that right?
Absolutely. So squamous cell carcinoma and basal cell carcinoma, in most cases, are extremely treatable and, in fact, curable diseases. That's not to minimize the severity of the morbidity that they can cause, in that these can sometimes spread or can cause a disfigurement. So there are some real consequences, but especially when caught early, the vast majority of these are easily curable with safe, fairly low risk in-office procedures.
What does your skin look like for people at home who are doing surveillance of their own skin? When should they be worried that something might be a cancer?
I love when patients ask me that, because it really implies a degree of engagement, and I love when patients take ownership for their health.
Yeah.
The unfortunate thing is there are myriad ways in which skin cancer can present. So skin cancer can be flat or elevated. It can be tan, pink, brown, black. It can be smooth or scaly. It can bleed or not. So there is such an incredible variety of ways in which skin cancer can present that it's really difficult to adequately equip patients with the tools that they would need to detect them themselves. We do talk about the so-called ABCDEs of melanoma, specifically A for asymmetry, where the two sides are a little bit different, B for borders that are irregular, so it's difficult to see where it starts and stops, C for color, so multiple colors within one lesion is a concerning sign. D for diameter is probably the least helpful, because skin cancer can be small, benign lesions can be big, but E for evolution is very helpful. Things that are changing, it's getting bigger, if the color is changing, if all of a sudden it's bleeding or is itchy or is painful, those are changes that should prompt a visit to see a dermatologist. So the best I can tell my patients is, listen, if you've got something that's new or you've got something that's changing and you're not sure about it, come in and have me take a look.
So you brought up melanoma. Of course, we just got done talking about sort of the relative ease of management for most skin cancers that are squamous cell, basal cell. You've got procedures like you're trained for, which is Mohs, surgery, minimizing how much skin you have to take off, but ultimately you're just taking it off. You're literally kind of just cutting away the cancer. Can't really do that with melanoma. Talk a little bit about what melanoma is and how common it is and that kind of thing.
Sure. So earlier we talked about melanocytes within the skin, those cells that produce pigment. So a melanoma is a cancer derived from one of those cells. It's literally a single melanocyte that had sufficient DNA damage to proliferate in a manner, excuse me, should we start over?
Yeah, go ahead. Yeah.
So earlier we talked about those cells within the skin called melanocytes that produce pigment. So melanoma is literally a cancer derived from one of those cells, a cell that has had adequate or enough damage to its DNA to proliferate in an uncontrolled manner, thus giving rise to a cancer. So first line of therapy for melanoma is still surgical excision in most cases. And the exact manner of that and nature of it would depend on multiple factors, primarily the depth of the primary tumor, meaning the more superficial it is at the time of biopsy, the lower the risk, and therefore the more conservative the treatment. It's those that are thicker or that seem to go more deeply at the time of biopsy that have a higher propensity for spread. Still, in most cases, unless there is extensive distant spread, meaning it's already in other organs or distant parts of the skin, we're still relying primarily on surgical removal to treat that.
You know, just to interrupt you here, when I was a surgical resident, and we used to do quite a bit of reconstruction on large melanomas, and we would often do the resections too, you know, where they weren't really just where they just became things that were not necessarily something you could do in the office, whether that be on the scalp or something like that. But, you know, a diagnosis of melanoma, significant melanoma, was almost a death sentence. This was like probably 20 years ago. Things have changed, right? I mean, that's not the case anymore, which is, I mean, I've kind of been out of medicine for a while, but that was one of the things that I realized, wow, maybe it's not. People are living. Is that right? What happened?
This is one of the most exciting areas of our specialty. There's been a tremendous breakthrough over the last couple of decades in terms of management of advanced melanoma. And to be clear, I want to emphasize that we're talking about advanced melanoma now. So this is really primarily stages 3 and 4 melanoma, where it's spread already to lymph nodes or to distant parts of the body, respectively. Historically, 20 years ago, the median life expectancy for an individual with stage 4 melanoma was 6 months.
Yep.
Really terrible prognosis situations. I think that's what you're recalling.
Exactly.
So immunotherapy has been an absolute breakthrough in treating advanced melanoma. So immunotherapy is a series or a category of medications, including so-called checkpoint inhibitors, which can, to simplify things a little bit, be thought of as sort of more modern, more targeted forms of chemotherapy that actually activate a patient's immune system and employs the immune system to fight off cancer cells. So these immunotherapy medications have done such a good job at treating, not curing, but treating stage 4 melanoma, that now the median life expectancy for a patient with stage 4 melanoma is 6 years and not 6 months. So that's still not a curable disease. It's still a terrible diagnosis, but we have treatments now that are far better than what existed 20 years ago. So it's been really exciting to see that.
I'm curious what it is about melanoma in particular that makes it more susceptible to immunotherapy. I mean, obviously we can't use immunotherapy against, you know, a lot of other different kinds of cancers. What is it about what makes it more susceptible to this kind of treatment?
I don't think it's so much that there are unique properties of melanoma. I think it's more due to the fact that because melanoma has such a propensity for spread and to metastasize, that lots of resources are being put into looking specifically at what aspects of melanoma can be targeted by the immune system. But melanoma is not the only even skin cancer that's treated with immunotherapy. So there's FDA-approved immunotherapy for advanced squamous cell carcinoma as well, for the cases where that disease is more advanced. So it has more to do with the aggressive nature of melanoma in some cases, and the fact that more people are studying it for that reason.
So that's really exciting. I mean, and what has obviously you were talking a little bit about the epidemiology and how common melanoma is in the treatment. How has that effectively changed? You know, what I was seeing when I was a surgical resident, as opposed to now. Like, maybe you could kind of go back to the epidemiology. I think I cut you off there a little bit and finish that thought.
So as I alluded to before, there are roughly 200,000 cases of melanoma in the U.S. every year, so pretty significant disease burden. There are roughly 8,000 melanoma deaths per year. And I think what's most interesting here is that while the incidence of melanoma is on the rise, for various reasons, and that's not fully understood, the number of deaths from melanoma is decreasing in time, fortunately, I think in large part due to advances in immunotherapy, as we've discussed, but also just due to increased detection. You know, patients are more aware, physicians are more aware, and I think we're doing a better job at catching these cancers at earlier stages when they're more treatable.
What do you think? Okay, so I guess one last question I want to ask you is, this show is really sort of forward thinking. It's, you know, really focusing on what's out there in the future and what kinds of things that we can be looking forward to You're an MD and a PhD. I mean, you are sort of on the cutting edge of things. When you look at what's out there and what it might sound almost, almost like science fiction that might be real in the future in the field of dermatology, what does that make you think of, if anything?
Artificial intelligence. AI is going to be a huge part of what we do, well, really in every aspect of our lives. Medicine's no exception. And I think dermatology is a great example. I embrace it, and I look forward to the day where my patients can step into a scanner, have full body imaging, have a validated software program that can screen and undoubtedly do a better job at detecting very early skin cancers than I or any other human could possibly do. I don't think that cuts me out of the loop. I think that I'll still get to say hi to my patients 20 years from now, but I think it'll make me much better at what I do and more efficient at what I do, and I think it'll make us better physicians. So I see that change coming. It's not going to be long.
Yeah.
It's not going to be long at all.
Have you seen any sort of programs or people talking
Absolutely.
to you about that already?
Yeah, the software is out there. It's being studied. It's not yet ready for prime time. And there are a lot of hurdles. There's technology that would be required as well. So there's cost involved and a matter of where do you store it. But it is being heavily studied. And I have no doubt that within 10 years, probably less time than that, it'll be a big part of what it looks like to get your skin screened for skin cancer.
Thanks so much for being on Sapio. Dr. Corey Frucht, MD, PhD. Corey, how can people find your practice? What's the URL?
www.santabarbaraskincare.com.
Thanks so much for being on the program.
Thanks for having me, Buck.
Thanks for listening to Sapio with Buck Joffrey. A quick reminder that while I am, in fact, a surgeon, nothing I say should be construed as medical advice. Now, make sure to include your physician in any medical decisions you make. And also, if you're enjoying the show, please make sure to show your support with a like, share, or subscribe. Until next time, this is Buck Joffrey for Sapio with Buck Joffrey.